Two, one. Please start, sir.
Yeah.
Yeah, good evening,
Very,
everyone.
very, yeah. Shall I
Yes,
start?
yeah. So I'll just introduce you as a
Yeah.
speaker. So, good evening, everyone, and welcome for today's virtual scientific session. And our first speaker for the meeting is Dr. Dipen Sheth. Dr. Dipen Sheth is a VR surgeon from Mumbai with expertise in the diagnosis and management of retinal diseases, including diabetic retinopathy, retinal detachment, macular disorders, and uveitis. Dr. Dipen completed his MBBS from TMC Nair Hospital, Mumbai, DNB Ophthalmology from Aditya Jot Eye Hospital, and a fellowship from Shri Ganpati Netralaya. With over 3,000 vitreoretinal procedures and surgeries to his credit, Dr. Dipen has extensive experience in retinal surgery, laser treatments, and intravitreal injections. So, with this, I invite Dr. Dipen Sheth for his presentation. Over to you, sir.
Yeah. Thank you, Shashil. Very warm welcome to all those who are present here. So today I'm going to brush upon neovascular ARMD in a very basic form so that it helps all our general ophthalmologists. Okay. I am Dr. Deepan Seth. I am a vitreoretinal surgeon in Mumbai. Yeah. So, what sort of a problem we are looking at? The world's population is a staggering 8.2 billion people. It is estimated that the number of people with AMD is around 196 millions, which is going to projected to increase to 288 millions by 2040. These estimates indicate the substantial explosion of global burden of AMD. So what I personally feel is there is a lot of information related to health issues floating around on social media and WhatsApp groups. People have started realizing those health issues and they actually pick up the symptoms early and they seek medical advice. That's the reason the incidence of new cases reporting is increasing tremendously. It is in a way helping us because that reduces the burden uh, of ARMD per se. So, what symptoms do they present with? They have a profound effect on patient's quality of life. Most of the symptoms are related to the central vision, which can be distortion of images, crooked letters, blurring of the central vision, and central scotoma. Symptoms of AMD usually appear suddenly and they worsen rapidly. Coming to stages of AMD, basically they are categorized to early, intermediate, and late stages. The early and intermediate AMD usually do not produce central symptoms unless when the deposits, which are called as Dusan, they present subfoveally. These are nothing but lipid and protein deposits in the RPE layer. Late AMD is the vision threatening stage, which can actually present with the dry form, which is an atrophic form of AMD, and a neovascular form. The neovascular form is the most aggressive form because it can present with a central defect, which leads to a rapid loss of vision. Now, coming to diagnosis. Now, diagnosis is multifactorial. Obviously, for all the patients who present in our OPD, we take the vision, the distant vision and the near vision. Near vision is of utmost importance because that is what is affected in the early stages. Screening of all the elderly patients with home AMSLers actually helps us a lot. Retinal examination with a 78 or a 90 diopter slit lamp biomicroscopy can clinch the diagnosis, especially when the foveal reflex is absent, when there are pre-retinal hemorrhages, or you find some SRF in the central area. Next, we come to OCT. OCT is very profoundly used, and there are options of OCT angio also available. With the advent of OCT and the further advances in technology of OCT angio, fluorescent angiography and ICG angiography are limited to a very handful of cases now because they are invasive tests. AMD management. Now, what is mentioned over here, time loss with vision loss, is very, very crucial. This is the perhaps the only condition on the of the eye wherein I tell the patient to take the treatment when the vision is good. So the goal primarily is to reduce the treatment burden while maintaining vision gains. If left untreated, permanent loss of vision can occur rapidly after the onset of symptoms. A very important point here is patient counseling, also the relatives counseling. A lot of chair time in the first visit, first consultation can actually reduce your chair time in the follow-ups. Okay, and patient becomes more compliant to taking longer treatments, which is the key here in AMD management. So, what are the factors which drive the key mechanism behind the pathogenesis of wet AMD? So, the vascular endothelium of the retina and the choroid, they have got the receptors which are like VEGF receptor 1, receptor 2, receptor 3, Ang2 receptors. Okay, a lot of antigens like VEGF A, VEGF B, VEGF C and D, and placental growth factor. They bind to these receptors and they cause activation of the receptors, resulting in increased vascular leakage, angiogenesis, edema, and inflammation. Pathological result is the neovascularization. So the VEGF-A chemical acts via receptor 1 and 2. However, the placental growth factor, it acts both directly via the receptor 1 and indirectly via the receptor 2 because it displaces the VEGF-A from the receptor 1. So the anti-VEGFs available in the commercial market, bevacizumab, ranibizumab, and brolucizumab, all of these act by binding to VEGF-A. So VEGF-B and placental growth factor are left uninhibited and they act via the receptors, further causing progression. So here we mention even if VEGF-A is completely blocked, the B and placental growth factor would still be able to bind the receptors and therefore contribute to downstream pathological effects. Here we see that aflibercept estimated human half-life is around 10 days, which is almost twice or twice the half-life of the other anti-VEGFs. Aflibercept binds to VEGF-A, VEGF-B as well as placental growth factor. Thus, it totally stops the activation of VEGF receptor 1 and receptor 2, leading to an enhanced effect as compared to the other molecules. So, how does it fare when we look into the randomized control trials and the real world evidences? So, this slide summarizes the Altair study, which is a phase 4 multi-center randomized trial of 247 treatment naive AMD patients which who were treated with aflibercept 2 mg using a treat and extend approach. Now, this treat and extend approach is very crucial because in the initial stages of treatment, patient may feel that the treatment burden is more, but however, looking at the long term effect, it reduces the number of injections, maintaining the visual gain, which is a very important point here. Patients were randomized to either a 2 week or a 4 week interval adjustment at visual outcomes at week 96. Both the groups achieved meaningful vision gains, with the best corrected visual acuity improving to almost more than plus 6 letters in both the groups. The number of injections required for both the arms were almost 10.4, which is like say 11 injections in the first 2 years. A very important point here is we see the durability outcomes. By the final visit at week 96, almost more than 40% of the patients in both the arms, the 2 weeks adjustment and the 4 weeks adjustment arm, had successfully reached a 16-week treatment interval. The key takeaway here is that aflibercept maintained vision gains with relatively few injections, and nearly half the patients could be extended to a 16-week, which is a 4-month interval by 2 years, which is almost like say 3 to 4 injections in a year. Okay. Yeah. So it also demonstrated unsurprised durability with a proactive treat and extend regimen, extending up to 60% of patients to Q12. That means a 3-month interval of injections. Okay, this is a very important outcome. Okay, almost 96% patients who were extended to a 4-month interval, maintain this interval to week 96 and beyond with aflibercept. Okay. See, the other study is the View 1 and the View 2. View 1 was a study which was conducted in North America. View 2 was conducted in Europe and Pan Asia, wherein the primary endpoint at 52 weeks we see a vision gain of 10.4 letters. This study was designed in a way that the patient received fixed intervals, injections at 2 months, extending the period to around 5 years. The vision gains with aflibercept were maintained throughout the 5 years. Now, the real world evidence is, if you look at the real world evidences, this is a registry, fight retinal blindness registry. With the treat and extend achieved very good vision gains, visual acuity gain with a reduction in the treatment burden in the second year. Okay, this demonstrated ability to maintain vision gains with extended dosing intervals more than 12 weeks in routine clinical practice. This is the real world scenario. So here we can see on the left the outcomes of the aflibercept RCTs. View fixed Q8 trials showed significant vision improvement of 8 letters in the years 1 and 2. LTA treat and extend trial also showed comparable outcomes with reduced treatment burden. 60% patients achieved an injection interval of 12 weeks or more, which is pretty good. On the right side we see the real world study using a 8-week fixed regimen. It has also delivered a 8-letter gain, which is comparable with those observed in the View trials. The remaining studies using the treat and extend regimen also showed satisfactory visual outcomes while reducing the number of injections over time, like the Altair study. Now, how is aflibercept as a choice in the PCVs? So, PCV is not very common globally. However, it is more prevalent across patient populations then previously it was thought Indian population do have a large number of PCV predilections. PCV may be underdiagnosed in Caucasian population by up to twofold or more. Aflibercept monotherapy achieves clinically meaningful visual outcomes in patients with subtypes of NAMD such as PCV. Now this Planet study was conducted initially with the loading dose of 3 monthly doses of aflibercept 2 mg. Further randomization was done equally in 2 arms, and the primary endpoint was 52 weeks and 96 weeks. In one of the arm, aflibercept Q8 monotherapy was facilitated with the sham rescue treatment. In the other arm was subjected to an active PDT treatment as a rescue therapy up to 52 weeks. Beyond 52 weeks, the aflibercept protocol was changed to treat and extend with a sham rescue or a active PDT treatment. Yeah. So what does the study show? So at 52 weeks into the study, the primary endpoint, the mean change in the best corrected visual acuity from baseline was more than 10.8 letters in both the arms, whether it was a sham rescue PDT or an active rescue PDT. Further extending the study in the year 2 with an optional treat and extend dosing, the letter gains were maintained more than 10 letters in the sham therapy and more than 9 letters in the rescue PDT therapy. So the injection intervals can be increased in the second year of aflibercept with maintenance of visual acuity achieved in the first year. That is a very important point in PCV because PCV patients tend to lose vision very rapidly and profoundly. At least 94% of the patients across both the study groups avoided vision loss of less than 15 letters from baseline to week 96, and 82% of the patients across both the study groups had no evidence of active polypoidal lesions at 96 weeks. In direct comparison with the results of Everest trial suggested aflibercept monotherapy provided numerically higher visual acuity gains than ranibizumab with a baseline active PDT. By week 96, 17% of the patient required rescue therapy, 16% of the patient in the aflibercept monotherapy group, and 18% in the intravitreal aflibercept with the rescue PDT group. That means around 17% of the patient only required rescue PDT therapy of the total 100% enrolled. So in both the treatment arms, more than 80% of the patients showed no evidence of any active polyps at week 52 or 96. So outcomes in the real world studies with aflibercept monotherapy in patients with PCV are in line with the results from the clinical trials. The efficacy of aflibercept in patients with PCV translates from clinical trials to a real world setting. It achieves clinically meaningful visual outcomes in patients with subtypes of neurovascular AMD such as PCV. Again, this is showing real world case series when we compare with aflibercept in PCV trials, in randomized control trials, with the complete polyp regression we see in the real world evidences. Ocular safety with anti-VEGF agents, intraocular inflammation and vasculitis with or without occlusion, very low reported rates of inflammation and retinal vasculitis in clinical practice with aflibercept. It is included in safety sections of US label based on post-marketing experience from 2011 to 2023. Post-marketing rate per 10,000 injections showed a very insignificant numbers with relation to retinal vasculitis and occlusive retinal vasculitis. So its efficacy and safety profile has been established across all RCTs and is supported by over a decade of real-world monitoring. Rate of endophthalmitis is 0.6 in 10,000 units. Thank you.
Yeah, thank you, sir, for the wonderful presentation. And with this, we move on to the next speaker, Dr. Anil Shah. Dr. Anil Shah is a VR surgeon from Vadodara with expertise in diagnosis and treatment of retinal disorders. A gold medalist from Baroda Medical College and university topper in ophthalmology. She received advanced retinal training at Dr. Banker's Retina Institute, Ahmedabad, and Yonsei University Hospital, South Korea. She has performed over 800 vitreoretinal surgeries and holds prestigious fellowships, including FICO and FAICO. Dr. Anil Shah currently practices at Sunshine Global Hospital, Vadodara, and serves as a visiting retina specialist at SIC Hospital. So with this, I invite Dr. Anil Shah for her presentation. Over to you, ma'am.
Yeah, hello. Thank you for the nice introduction. I want Mr. Yash to produce my presentation.
Yes, ma'am. I'm sharing the screen. Give me just 1 minute. I'm sharing. So I'll change the slide once you tell me.
Yeah. I'll be telling you once I finish about speaking about a slide. So
Sure,
I'll be talking about evaluating the need for the change, evidence and insight on the anti-VEGF therapies which currently available for DME and wet AMD. So change the slide. Next slide. So yeah, this is the disclaimer. Next slide. So as we know, the current management in neovascular AMD has multiple choice of anti-VEGF, and as it is mentioned on the screen that Bevacid, ranibizumab, aflibercept, bevacizumab, and faricimab are current options available. And although there is no cure, but we know that the goal of our treatment is drying the eye and inhibiting the new vessel from forming and fluid. Decreasing the fluid, so that ultimately improves the vision of the patient. But however, there is also a gap. There is also a gap and a lot of challenges in achieving that goal, especially for our neovascular AMD patients. Next slide. Yeah. So what are the challenges that we normally face while we use the anti-VEGF agents? So as we know that there is after the introduction of anti-VEGF agent, the therapy for neovascular EMD has become very easy, but still there are challenges that there is no significant inter-individual. There is a difference in the individual response to the anti-VEGF agent, and also there are multiple anti-VEGF agents and there are multiple configuration of their molecules. So and also there is no consensus on how we classify that the patient is having an optimum response to the treatment or whether the patient is not having a response at all, like there is lack of it. So with this, so that is the current challenges in the wet AMD management with anti-VEGF. Next slide. How do we actually grade the response to the treatment? Primary response, usually we grade when then there is 1 month following the last loading dose of the anti-VEGF, and the secondary response will be anytime after the 4th visit. And there is always a ceiling effect that can negate the currently used functional metrics, such as there are improvement in the BCVA, which is more than 5 letter of improvement in BCVA, which can be used. And the changes in the visual function is after the visual acuity. We see the changes in the OCT, which is the morphological changes that we see in the OCT. ICG is also one of the modalities, but it is primarily kept aside for the IPCV patients, or unless we have a diagnosis suspicion of IPCV or RAP, or whether we are thinking that the anti-VEGF therapy is not giving any response, then we go ahead and look for ICG. Next slide. So here is a chart which tells us that how we actually grade or define the response to the anti-VEGF therapy. So good response will be morphologically, that is the OCT finding where there is absence of subretinal fluid or intraretinal fluid or any cyst, and there is reduction in the central retinal thickness for more than 75%. And functionally, if the patient is having improvement in the vision for more than 5 letters. We grade a partial response when there is reduction of CRT between 25 to 75% from the baseline value with persistence of SRF and intraretinal fluid. Or even if there are new appearance, then also it is when the thickness is reduced, it is a partial improvement. And visual acuity change is less than 5, which is between 1 to 5 letter, then it is a partial response to the therapy. And a poor response will be there is 0 to less than 25% reduction in the retinal thickness, and there is persistence of all the OCT, other findings in the OCT, and visual acuity gain is less than 4, that is 0 to 4 letters. And the non-response will be there is no changing at all in the OCT, or there is increase in the retinal thickness or subretinal fluid or intraretinal fluid, and there is reduction in the letter, there is decline in the visual acuity. So this is how we define the response to anti-VEGF treatment. So when we decide to switch to a newer anti-VEGF agent, next slide. So here are some of the real world case studies. So when we have compared a newer molecule, which is a faricimab, and we have compared it with the aflibercept. So it's not like we are comparing it, but when the patient switched from aflibercept to faricimab, what are the findings that they had? So after 3 faricimab injection, when they switched, there was no significant visual gain. Again, after 4 faricimab injection also, the 2 studies showed that there is no significant improvement in the vision. The vision improvement was limited. Next slide. So in the other 2 studies also, it is shown that 92% of the patient who switched from aflibercept to faricimab and discontinued the treatment with faricimab because of insufficient efficacy. So in this, we saw that there is no actual change in the visual acuity, and there is minimal reduction in the central retinal thickness, and majority did not extend the treatment beyond Q8, and 92% who switched from aflibercept to faricimab discontinued the treatment because of insufficient efficacy. Next slide. 71% of here also in the Kishi et al., it is again the same finding that 71% of the patient who switched from aflibercept to faricimab remained on less than Q8 interval from the baseline. So There was, even after the 3 injection of faricimab, there was no change in visual acuity. The BCVA did not change at all. There was mixed outcome on the anatomical parameter, whether and majority not extended beyond Q8. So more than 70% had treatment interval of less than 8 weeks. They needed injection within 8 weeks. Next slide. So again, in the Hera et al., after the 3 loading doses, there was significantly better visual outcome with aflibercept compared to faricimab. So after the 3 injection, which is month 3, significant improvement in visual acuity from the baseline was noted in aflibercept, when we can see the p-value is significant versus the faricimab group, meant that the central retinal thickness markedly improved from baseline to month 3 in both aflibercept and faricimab group, but the clinical significance was more with the aflibercept. Next slide. In the Bailey C et al., it was again the same thing when the 72.1% who were previously treated eyes, they switched from aflibercept. The studies were, this was a study which was done on DME when they, 6-month real world study of faricimab, when they were switched to faricimab, they have again shown that there are limited vision gains. Next slide. The injection sequences are shown over here, and 86% of patients who switched from aflibercept are shown. And despite the multiple faricimab injection, majority of the patients are in less than Q8 interval only. So again, we can conclude that there is a limited improvement on intravitreal, there is interval of TME patients as well. Next slide. This study again is saying the same thing. Where there was a switch. The findings, can you zoom on the findings, please? Yeah, so the findings. Yes, I can't see the slide.
Ma'am, it is it is in sharing mode only. Can someone confirm?
Please share it, please.
Okay, I'll reshare it.
And we directly go to the, yeah. Just switch to the next slide. Yeah, switch to the next slide. Yeah. So now let's talk about whether if we switch the pathways, if we switch the treatment by thinking that the pathway of the anti-VEGF blockage is different. So is the therapy beneficial? Next. So there are several different approaches that have been attempted in the past to improve the patient outcome, whereas aflibercept was used along with the nesvazumab and faricimab and brolucizumab and the ranibizumab PDS. Next slide. So the first one where there is aflibercept 2 milligram was given with nesvazumab. Next slide. So here in the Ruby and Onyx, it targeted both the angiotensin 2 and the VEGF receptor pathway, but it did not provide additional improvement in the vision. Next. Next. Yeah, so let's look at the faricimab now. Next slide. Which claims to block the angiopoietin 2. So in this therapy, the faricimab was non-inferior to aflibercept 2 milligram for maintaining the mean BCVA change. So again, it was non-inferior efficacy, both in AMD and DME. Next. In Avenue clinical studies, it was a ranibizumab and faricimab, both of these drug use, and faricimab failed to meet the primary endpoint of superiority to ranibizumab for BCVA gain at even week 36, and level of angiotensin 2 inhibitor were similar between the two agents. So ranibizumab and faricimab were inhibiting angiotensin 2, angiopoietin 2 at the same level, suggesting that there is no anti-angiotensin 2, angiopoietin 2 molecule of faricimab having additional benefit over any other anti-VEGF monotherapy. Next slide. Again, in this study, this is again the previous thing that we talked about, that the role of angiopoietin 2 has not been established to show any clinical effectiveness. Next. And also it is stated by US FDA. So aflibercept has shown the most durable effect in blocking the effect of human VEGF and Ang2 levels in this preclinical rabbit model as well. This study shows that. Next. So basically, the angiopoietin is not the one which is the master regulator. However, the VEGF receptor pathway is the main master regulator in retinal disease. Next. The VEGF pathway is the master regulator, and the members of the VEGF family, and there are multiple cell type under the pathological condition, and the VEGF agents, they bind to the VEGF receptor 1, and both VEGF-A and PIGF, they are the key component of inflammatory response. So the drug which target the both will target most pathologies related to the VEGF. Next. So aflibercept is only widely approved agent that blocks all VEGF receptor 1 ligand and the key VEGF receptor 2, because it targets VEGF receptor and the master regulator of the disease pathology, and additionally it also targets the key ligand PIGF. Next. So in summary, with aflibercept 2 gram already targeting the key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcome for patient. Next, increasing the molar dose of an anti-VEGF agent may have the potential to offer patients more through extended VEGF suppression. So have maximized outcome of our patients, or can we go further with the disease control? Aflibercept 2 has set the bar high for the treatment. So it is basic standard care of vision gains, durability, and safety profile across all the indications. Aflibercept targets the ligand of the VEGF pathway, the master regulator of pathologies, and data from Pulsar and Photon suggest that aflibercept 8 gram has potential for greater and longer lasting control for underlying disease compared with aflibercept 2 gram, though the sustainable disease through the sustainable disease control. That's all. Thank you.
Yeah, thank you, ma'am, for the wonderful and insightful presentation. And we have one question from the participant. Any experience with aflibercept versus faricimab? Any differences, visual acuity gains, OCT changes, and frequency of injections in your clinical practice?
Yeah. I have actually, I can't compare it because I have used the faricimab injection along in the patients only after they have become resistant to Eylea, or where they have told me that we want to switch the agent, and when I felt the need of switching the agent. So and so far with my patients, I would be honest that the faricimab was working well. It could be because the patient had a longer duration between the two treatments. When they took the Eylea and when they next took faricimab, there was a longer duration. It could be because of that, or it could be because the faricimab actually worked with them. So I have had a good experience of the switch in my patients, like 2 or 3 of my patients. But I would not say that the Eylea did not work for them. It also worked, but we decided to switch after giving, multiple doses of Eylea. Maybe say 8 or 10 doses of Eylea.
Okay, thank you so much, ma'am. Thank you for sharing your experience. Sushil bhai? Hello? Sushil bhai?
Well, sir.
I think if there is no any more questions, we are good to close the meeting then. So thank you so much, Dr. Deepan and Dr. Anand, for sharing these wonderful presentations and
Thank you.
sharing your experience as well.
Yeah, thank you for the opportunity.
Thank you so much. Thank you, ma'am.
Thank you.
Tech team, we are good to close the meeting.